Today's session is a treat. We invited Dr. Gary Schwartz, someone who has built an exceptionally efficient and effective regional anesthesia practice, to share the practical wisdom that he uses every day. Gary, who practices in New York City, will walk you through his most commonly used nerve blocks and fascial plane blocks, and more importantly, the technique nuances and mixtures that help him get consistent, reliable, and long-lasting analgesia, even in a high-paced practice environment. From optimizing the Injectate to understanding the planes, the angles, and the little habits that make blocks truly work, he's going to give you the playbook that he has refined over thousands of cases. This is a rare opportunity to learn the practical side of regional anesthesia from someone who does it at a scale every day. Let's dive in.
Hello, I'm Gary Schwartz. I work at ABP Integrative Pain and Wellness and Maimonides Medical Center in Kings County, New York. Today we're going to be speaking about framing the value of precision in regional anesthesia. We want better outcomes, longer lasting pain control, and reduced opiate use for our patients. So for regional anesthesia, we're not just talking about techniques to optimize the patient experience, there's also medications, which is where EXPAREL comes in. It's a multivesicular liposome, which has a delayed release, so it gives improved patient pain relief and a better recovery from their surgical procedure. We have to tailor the concentration of their drug to have adequate spread of the medication without compromising efficacy, and we'll talk about mixing with different medications today. And the site-specific considerations. Obviously, technique matters, but we have to put the EXPAREL in the correct area for optimal delivery and pain relief for our patients. We will now be discussing upper extremity blocks, including the Interscalene brachial plexus nerve block. The Interscalene brachial plexus block, which is one of our optimal blocks for shoulder surgery. We use it for shoulder arthroscopies and shoulder arthroplasties. Also could use it for clavicular fractures. What we're doing is we're depositing our local anesthetic mixture of EXPAREL and bupivacaine between the anterior and middle scalene muscles. That's where the brachial plexus lies. We have the patient's head turned away from the side that we are blocking, and I put a small group of towels underneath the head so I have optimal placement of the neck and area to place my needle. You start scanning in the transverse position until I see the interscalene brachial plexus, which looks like a stoplight sign over here. In the video, we see the C5 and C6 nerve root between the anterior and middle scalene muscle. We advanced our needle in plane towards the brachial plexus from a lateral to medial direction, or posterior to anterior. The needle does not hit the nerve, we go into the plexus right next to the nerve. As you see the local anesthetic spreading in the video, first I drop local anesthetic, usually 0.5% bupivacaine, and then after I drop 2 mLs of that, I give my admixture, which is about 8 mLs of the 0.5% bupivacaine with 10 mLs of EXPAREL, liposome bupivacaine, and I watch the plexus push over to the side. That's how I know I have adequate spread. This gives the patient adequate shoulder pain relief for up to 72 hours post-procedure. Now we're going to discuss some tips for the difficult patients or larger patients. One thing I do is I fold up a towel and put it over half the head and have the patient turn their head like so it gives me more space to work in their neck with the needle. Another tip that I do is sometimes have the patient go into a semi-Fowler's or lateral decubitus position where they're on their side. This is especially helpful in the obese patients or patients, male or female, with large shoulders. Another tip and trick that I utilize is have the patient reach into their imaginary wallet or front part of their pants to open up the space between the shoulder and the neck. And another tip that I have is to go down to the supraclavicular block, find the subclavian artery, and scan up to find the nerves. The most important thing I do is that I give some local anesthetic first to make sure that my needle tip is in the adequate plane, and then I inject my admixture of liposome bupivacaine, which is EXPAREL, along with the rest of my local anesthetic. As we give the injection, the EXPAREL might look a starry-like appearance or a snow globe, so I know I'm injecting it properly. We will now be discussing lower extremity blocks, including adductor canal block, popliteal nerve block at the sciatic fossa, and also the peng block. We're going to be speaking about the adductor canal block. We utilize this block for knee arthroplasties, knee arthroscopies, and sometimes foot and ankle surgery. We're using a linear probe the majority of the time in an in-plane approach. The patient is placed supine with their legs slightly externally rotated, and we put the probe mid-thigh. Here we could see the branch of the femoral artery. We see the sartorius muscle, and we're going in plane from lateral to medial, where we pierce through the sartorius muscle, and we're going to inject our local anesthetic mixture by the saphenous nerve and also by the nerve to the vastus medialis. For this block, we utilize 10 mL of 0.25% bupivacaine and 10 mL exparel. It's important to not only block the saphenous nerve, but also block the nerve to the vastus medialis. That provides excellent coverage of pain relief for the knee, especially after knee arthroplasties. The benefits of this block is it is a motor-sparing block where we do not get quad weakness. So after our total knee arthroplasties, our patients could get up and ambulate, along with a multimodal approach to anesthetics. Some tips and tricks is sometimes it's easier to externally rotate the leg to visualize the muscles, the artery, and also the saphenous nerve and the nerve to the vastus medialis. Occasionally, in a large patient or a patient with a high BMI, you may have to utilize a curvilinear probe to visualize the muscles. The block is usually very quick to perform and is quite beneficial for total knee arthroplasty patients. It is imperative to inject local anesthetic by the saphenous nerve and the nerve to the vastus medialis to ensure proper spread of the medication and also knee coverage for pain relief. We will now be discussing the popliteal sciatic nerve block. This is one of my favorite blocks. I love seeing the nerve anatomy on here. It's useful for foot and ankle surgery. It is useful for ankle fractures, also amputations below the knee. Here we're going to block the sciatic nerve where it branches off into the tibial nerve and the common peroneal nerve. The benefits of this block is we could use this block with the patient supine, prone, or lateral. A lot of times if I have difficult anatomy, I prefer to have the patient supine, like in this video where I'm holding the probe underneath and I'm scanning in the popliteal crease where I visualize the popliteal artery, the tibial nerve, and the common peroneal nerve. You can go from medial to lateral or lateral to medial. A lot of the times I prefer to go from lateral to medial in this position. I take my needle in an in-plane approach and I try to block the nerves where the common peroneal and the tibial nerves branch together. I give a combination of 15 mL of 0.5% bupivacaine with 10 mL exparel. We utilize an in-plane approach from lateral to medial. We watch our needle tip the whole time, and we surround our local anesthetic around the common peroneal nerve and the tibial nerve, where they join together. To me, it always looks like an amoeba coming together, and we see the local anesthetic spread circumferentially around both of these nerves. That's how you know you have an adequate block. You have to warn the patient, be careful. They may have a foot drop after the surgery. What we expect from the motor weakness, so be careful of weight bearing. For a heavier set patient or difficult anatomy, I find the supine position easier. I prop the leg up. I find it easier to give external pressure from anterior to posterior in this direction where you have a good view of the spread. And we want to see the local anesthetic surrounding both the tibial nerve and the common peroneal nerve. Now we will talk about the PENG block. The PENG block is optimal to use for hip fracture surgeries and also hip arthroplasties or total hip replacements. Here we are looking at the femoral crease to find the femoral nerve, the femoral artery. We're looking for the iliacus muscle, the psoas tendon, the AIIS, and the ASIS. The patient will be supine for this procedure. As we're scanning, you could use a linear probe or a curvilinear probe. The anatomical variance we're looking to block is this. It was looking to block the accessory obturator nerve, the articular branches of the femoral nerve, and the obturator nerve. Usually I use a curvilinear probe to this, and I want to visualize the psoas tendon, the femoral artery, the femoral nerve, and the superior pubic ramus. Here I'm looking as an in-plane approach from lateral to medial. My needle will be coming over the AIS towards the pubic ramus while avoiding the psoas tendon. You do not want to inject the psoas tendon. My needle will be coming in plane. Most of the time I'm using 5 mL 0.25% bupivacaine, and 5 to 10 mL of exparel liposomal bupivacaine. My needle is going from a lateral to medial position, and I anticipate injecting lateral to the psoas tendon where I contact the pubic ramus, which is the bone. I would like to see spread lateral to medially of the local anesthetic mixture underneath the tendon. Now on to tips and tricks for the PENG block. 1. Utilize this block for femoral neck and intertrochanteric fractures. Anything distal to this, the PENG block will not cover. Again, do not utilize more than 20 mL of your local anesthetic mixture, as you can get an inadvertent femoral nerve block. I usually utilize 10 mLs of Exparel with 5 mLs of 0.25% bupivacaine for adequate coverage of this block. You want to take time to ensure not to inject inside the iliacus muscle because then you can get a temporary femoral nerve block. We will now be discussing abdominal wall blocks, including the tap block and the QL block. The next block we're going to be talking about is the tap block. We use this for lower abdominal incisions, including cesarean sections. We use a linear transducer and an in-plane approach as we go through the external oblique, the internal oblique, and the transverse abdominis muscle. I utilize an admixture of 20 mLs 0.25% bupivacaine with 10 mLs Exparel. First, I usually pierce through the transverse abdominis muscle and I give some 0.25% bupivacaine. Then I continue my injection as I open up the fascial plane. I flatten my needle down and I maneuver my needle more laterally to ensure adequate spread of the local anesthetic. We utilize this procedure in almost all of our C-sections. This block is very easy to do. It does not take more than 1 minute per side. Be careful not to pierce through too far past the transverse abdominis muscle and pierce through the bowel. We will now be discussing the QL block, the quadratus lumborum block, which is utilized for anterior sensory and visceral coverage of the abdominal wall after surgeries. We use this for laparoscopic surgeries, robotic surgeries, and any surgery of the abdominal wall. This block gives a wider sensory coverage than our tap block and is an excellent source of multimodal analgesia and postoperative recovery. For these blocks, we utilize an admixture, each side 20 mLs 0.25% bupivacaine, 10 mLs of Exparel, and this gives relief up to 72 hours after surgery. A lot of times for this block, we use a curvilinear in-plane approach as we inject medication. I will now show on the video using a anterior QL block where we are injecting local anesthetic between the QL muscle and the psoas major muscle. You see the TP, the transverse process, in view in the erectae spinae muscle. The QL muscle always looks hypoechoic compared to the other muscles. That's how you notice it. It looks darker between the erectae spinae and the psoas major muscle. When I'm injecting my admixture of local anesthetic and liposome bupivacaine, I always start with 5 mLs of local anesthetic just to make sure I am in the correct fascial plane in this block, and then I give the rest of my admixture. This block should unzip just like our tap blocks. It is important, as sometimes this block is deep, that we use a curvilinear probe and also sometimes utilize a nerve stimulator technique to make sure we are not stimulating the psoas muscle in this block. If you inject the local anesthetic in the psoas muscle, you could get some quadricep and or leg weakness. So it's important we try to avoid that. When you are in the correct plane with this block, you should not see a nerve twitch. If you're in the psoas muscle, you will see a quadricep twitch. We will now be discussing thoracic wall blocks, including PEX block and ESP blocks. The PEX blocks, formerly called PEX 1 and PEX 2, now interpectoral fascial plane block and pectoserratus block. Utilized for breast surgery, chest wall surgery, including mastectomy, lumpectomies, AICD, or pacemaker placement. We utilize a linear transducer and an in-plane approach where we inject local anesthetic between the pec minor and the serratus muscles and between the pec major and the pec minor. Utilizing this block, I first aim towards the rib, between the third and fourth rib, between the pec minor and the serratus muscles, and then I drop local anesthetic there. The benefit of aiming towards the rib, if you lose your needle tip, you will not pass the rib and hit the pleura and potentially have a pneumothorax. After I drop 20 mLs of my local anesthetic mixture between the pec minor and the pec serratus, I pull back the needle and I drop 10 mLs of my local anesthetic mixture between the pec major and the pec minor. Usually this is a bilateral procedure and I use 20 mLs of 0.25% bupivacaine with 10 mLs of Exparel on each side. The next block we're going to talk about is the erectae spinae fascial plane block. The erectae spinae is a group of muscles that goes from the top of the cranium all the way down to the sacrum. We utilize this fascial plane block in breast surgery, lumbar surgery, abdominal surgery, and thoracic surgery. It's very beneficial for our patients. We use a linear or curvilinear probe and we go in plane with our needle technique through the trapezius, through the rhomboid, through the erectae spinae muscles down to the transverse process. We utilize our needle to go through these muscles under the fascial plane, and we aim for one of the corners of the transverse process. This allows medication spread both cranially and caudate to optimize patient recovery and pain relief. I utilize a mixture of 20 mL 0.25% bupivacaine along with 10 mL Exparel per side. In this type of block, you want to see the erector spinae fascial plane lift up from the transverse process. I usually dose my medication in 3 to 5 mL aliquots to watch the erector spinae muscle lift up. I pause for a second to watch the erector spinae muscle drop down like an accordion and spread up and down as I continue my injection of the medication. The liposome bupivacaine Exparel will look like a starry snow globe appearance as I inject. Sometimes I utilize a curvilinear probe so I could view the cranial and caudate spread of the medications over multiple transverse processes. It is important to note that Exparel is part of EROS protocols Enhanced Recovery After Surgery, where we utilize multimodal analgesia to give the patients the best relief after surgical procedures. It's important to admix Exparel with plain bupivacaine in our regional field blocks to allow faster onset of pain relief for our patients.
Exparel, bupivacaine liposome injectable suspension, is indicated to produce post-surgical local analgesia via infiltration in patients aged 6 years and older, and regional analgesia in adults via an interscalene brachial plexus nerve block, sciatic nerve block in the popliteal fossa, and an adductor canal block. Safety and efficacy have not been established in other nerve blocks. Important safety information. Exparel is contraindicated in obstetrical paracervical block anesthesia. Adverse reactions reported in adults with an incidence greater than or equal to 10% following Exparel administration via infiltration were nausea, constipation, and vomiting. Adverse reactions reported in adults with an incidence greater than or equal to 10% following Exparel administration via nerve block were nausea, pyrexia, headache, and constipation. Adverse reactions with an incidence greater than equal to 10% following Exparel administration via infiltration in pediatric patients 6 to less than 17 years of age were nausea, vomiting, constipation, hypotension, anemia, muscle twitching, vision blurred, pruritus, and tachycardia. Do not admix lidocaine or other non-bupivacaine local anesthetics with Exparel. Exparel may be administered at least 20 minutes or more following local administration of lidocaine. Exparel is not recommended to be used in the following patient populations: patients less than 6 years old for infiltration, patients younger than 18 years old for nerve blocks, and / or pregnant patients. Because amide-type local anesthetics, such as bupivacaine, are metabolized by the liver, Exparel should be used cautiously in patients with hepatic disease.
With its depot foam technology, the medication stays where you inject it, so you have to be in the fascial plane and or next to the nerve/plexus to get adequate results. Thank you again for your time. I'm Dr. Gary Schwartz, and I hope to see you soon.
Gary, thank you for sharing that incredibly practical, experience-driven walkthrough. And to all of you watching, I hope these insights help you get more from your blocks, more consistency, more duration, and ultimately better patient comfort. And the real magic of regional anesthesia is in the details. And today's Gary showed exactly how focusing on those small details can elevate outcomes in a busy practice. If you like more content like this, or if you have cases and questions you'd like us to explore, join us through NYSORA's community. This is where conversations like this continue. Thank you for watching, and see you in the next session.